Hello everyone, this is the Dr. Madhusudan Rao and the program I teach medical students. Today I'll briefly touch upon the seventh cranial nerve, that is facial nerve. Before we go to these clinical lesions of facial nerve, we briefly talk on the anatomical features of the facial nerve. Facial nerve is a mixed nerve. It carries out the motor, sensory, and the secretory motor functions. It carries out the motor functions by supplying the muscles of facial expression, and it carries out the secretory motor functions because it supplies the lacrimal and the salivary glands. With regard to the sensory function, it is responsible for the taste sensation in the anterior two-thirds of the tongue, and for the general sensation, it innervates the pinna and the external auditory meters. Then we briefly talk about the pathways of the upper motor neurons and the lower motor neurons. We discuss about the features of the upper motor neuron lesion signs as well as the lower motor neuron signs. And we also talk about the various lesions involving the facial nerve at the level of its nucleus in the pons and during its course through the brain and its course at the pontomedullary junction, and it's how it is subjected to the injuries while it is coursing through the patellar part of the temporal bone. That means we are going to touch upon the upper motor neuron lesions and the lower motor neuron lesions of the facial nerve in this class. Well, before going to the clinical significance, I'll show you some of the pictures that shows the course of this facial nerve. This is the facial nerve in the patellar part of the temporal bone. We look at it as the geniculate ganglion and its branches to supply the structures in the face. Well, this is the picture showing the branches of the facial nerve innervating the muscles of face. And this picture shows the section of the pons showing the location of the facial nerve nucleus and the absence nerve nucleus and the facial nerve and the other cranial nerve, that is the absence nerve, coursing down to the pontomedullary junction before they exit. You will also see the nucleus solitarius, nucleus intermedius, and sensory nucleus of the trigeminal nerve in this particular picture. And this is the course of the facial nerve in the patellar part of the temporal bone, where it is accompanied by the vestibulocochlear nerve. This is again the facial nerve in the patellar part of the temporal bone, and its course in the facial canal and the branch to the stapedius and the cardia tympani branch of the lingual nerve joining the facial nerve in order to carry out the receive the taste sensations from the anterior tooth of the tongue. And you have got the extracranial segment after its exit from the stylomastoid foramen. You have got to remember the anatomy of the facial nerve in order to understand the clinical features, which we are going to discuss in course of time. Then, as I mentioned earlier, you see the features of the facial nerve. That is seventh cranial nerve, having the motor, sensory, and the parasympathetic functions to carry out the secretory motor functions. As such, the facial nerve innervates many structures in the face and neck. And this picture shows the motor innervation of the muscles of facial expression. Upper face receiving the innervation from both the hemispheres. Lower face is receiving the fibers from the contralateral hemisphere through the motor nuclei located in the palms. The motor nucleus for the upper face, that is dorsal nucleus, receives its upper motor neurons from both the hemispheres. So muscles of upper face is bilaterally innervated. Well, those of the lower face, the nucleus is receiving its upper motor neurons from the contralateral hemisphere. So lower face is innervated from the contralateral hemisphere only. So UMN lesions involves the lower face sparing the upper face. Then coming to the nucleus of the seventh cranial nerve. I already mentioned it has got the motor, sensory and secretory motor functions to carry out. So it should have its nucleus having these components in the pons. These are the functions which I already mentioned. There are the various pathways of the upper motor neuron and the lower motor neuron. Secretory motor pathway is carried out by the nuclei for the salivary and the lacrimal functions which are located in the pons. Okay, they receive the fibers from the higher centers. Higher centers for the secretory motor functions located in the hypothalamus as well as the postcentral gyrus, which run in the nervous intermediates down to the pons. From there, they enter the accompany the facial nerve to the nervous intermediates. Okay, they synapse into the geniculate ganglion. From there, the axons, along with the facial nerve, innervate the lacrimal and the salivary glands. This is the secretory motor pathway. The sensory pathways, there are two types: special sensory, that is taste sensory from the anterior, two-thirds of the tongue, carried by the branch caudal nerve, which will join the facial nerve. From there, the axons enter the pons. Okay, synapse in the nucleus solitarius. Then the fibers cross to the opposite side, ascend and reach the taste center and the postcentral gyrus and a part of the hypothalamus. This is how the sensory pathway for the taste sensation is carried out by the facial nerve. For the general sensation from the area of the external auditory meters and the pinna, they are carried by the facial nerve. Again, they synapse in the geniculate ganglion and the axons from the cell bodies of the located in the geniculate ganglion. They enter the pons to the sensory nucleus of the trigeminal nerve. They cross to the opposite side. They run under the medial lemniscus. Okay, reach the thalamus. From there, the axons end in the postcentral gyrus of the parietal lobe. This is the sensory pathway for the general sensation from the external auditory canal and the pinna that is carried out by the facial nerve to cover the sensory functions by the spatular nerve. So you understand the sensory pathway well. Then coming to the motor pathways, that is lower motor neuron. Lower motor neuron and its course is very important to be understood by the students. Okay, lower motor neuron starts from the motor nuclei of the facial nerve located in the upper pons to its supply to the muscles of facial expression. Okay, so upper motor neuron has got is divided into two parts. That is, one is the intracranial part and the extracranial part. Okay, intracranial segment could be, again, it could be intracerebral or extracerebral. Intracerebral part of the patient is that segment which run from the nucleus of the patient now in the upper parts down to the pontomedullary junction where it exits. So the facial nerve can be affected if this part of the uh, part of its course due to the occlusion to its blood supply, or due to the neoplasms, or due to the inflammations, or any other causes. Let's say about the uh, various tumors, ischemia, infections, etc. Besides the congenital anomalies that can affect this part of the facial nerve, resulting in various clinical manifestations. Because in this course of the facial nerve, it is in close proximity to the other structures like the nuclei of the other cranial nerves and the fibers of the other cranial nerves and the long sensory tracts and the motor tracts. So the manifestations will be a little more complex in the lesions of this particular segment of the facial nerve. Coming to the extracranial segment. Extracranial segment is from the point it enters into the external stigmatus during its course in the petrous part of the temporal bone till it exit at the stylomastoid foramen. It is subject to the injuries. Okay, that we are going to delve into the various clinical manifestations of the lesions of the facial nerve. Now, at this point, we have more or less completed the brief discussion on the anatomy of the facial nerve. Now, coming to the clinical considerations. So, it could be upper motor neuron lesion, it could be lower motor neuron lesions. Then look at the upper motor neuron lesion. Upper motor neuron lesion could be anywhere from the cerebral cortex down to its nucleus at the pons. The features are it involves the contralateral lower face weakness and the upper face is spared. Okay, in the lower face, lower motor neuron lesions, it causes the ipsilateral total facial palsy. You can see this diagrammatic representation of this particular lesion. Then coming to the upper motor neuron lesion in detail. So lesions could be anywhere from the precentral gyrus to the area of upper motor nerve cells and cell bodies near the nuclei of the facial motor nuclei in the pons. So the lesion could be at the cerebral cortex. Lesions could be involving the fibers while they are coursing through the internal capsule, okay, or it could be in the midbrain till its nucleus in the pons. So the causes could be stroke due to vascular occlusion, it could be due to tumors, infections, or vasculitis. So how does it manifest? As the weakness of the contralateral lower face and contralateral hemiplegia, contralateral sensory loss, depending upon the extent of the lesion. So this is all the lesions of the upper motor neurons. So they could be lesion could be in the cerebral cortex. If the facial nerve is affected by the lesion in the cerebral cortex, it involves the weakness of the contralateral lower face that we have already understood, and it is associated with seizures. The cortical lesion induces seizures. That is the most important clinical point that you have to remember to diagnose the lesion is in the cortex. And there is associated dysphagia if it involves the dominant hemisphere. Then it could be the lesion in the internal capsule. The capsular lesion manifests as the contralateral lower face weakness along with the contralateral hemiplegia, contralateral hemianesthesia, contralateral visual and auditory disturbances depending on the extent of the lesion, but there are no seizures, no aphasia. Remember this point. Then coming to the lower motor neuron lesion in the pons. It could be due to stroke, due to tumors, due to infections, or congenital anomaly. Okay. So what are the various syndromes associated with the lesion of the lower motor neuron in the pons? Once there is lower motor neuron lesion, there is ipsilateral total facial nerve palsy. Ipsilateral, that is on the side of the lesion. There is total facial weakness. In addition to that, depending upon the other structures affected in the pons, there are various syndromes described. That is Millard-Gubler and the Fowley's. There is a congenital syndrome called Mobius syndrome. So let us consider the features of these particular syndromes briefly. Coming to the inferior medial pontine syndrome. This is, as the term indicates, medial pontine syndrome. Structures in the medial part of the pons, they are affected. It is Fowley syndrome. What are the structures in the medial part of the pons? You have the facial nerve nucleus and the abscess nerve nucleus, which is superior medial to the facial nerve nucleus. Besides, there are corticospinal fibers, there are pyramidal fibers. The manifestations will be the ipsilateral facial nerve palsy, that is total facial palsy, and ipsilateral absence palsy with contralateral hemiplegia. Okay. Besides, there is parapontine reticular formation in the medial pons, which is also affected, resulting in ipsilateral horizontal gaze paralysis. Okay. If you remember the structures located in this part of the pons, it's very easy to understand the clinical presentation. Okay. These are the features of Fowley syndrome. Sometimes lesion can be extended, involving the some more structures in that part of the pons. That is, eighth nerve nucleus and the involvement of the sensory tracts. That is, spinothalamic tracts, and it can also involve the sympathetic chain, and it also can involve the medial lemniscus. When the lesion is extended little more laterally and inferiorly, it involves these structures presenting as the contralateral hemianesthesia because of the involvement of medial lemniscus, ipsilateral Horner syndrome because of the damage to the sympathetic chain, ipsilateral sensorineural deafness because eighth nerve is damaged. Well, there is ipsilateral pain and temperature loss because of the injury to the spinal nucleus of the trigeminal nerve. So, in Fowler's syndrome, when the lesion extends towards downwards laterally, it involves these particular structures with the additional clinical manifestations. So this is very easy to remember once you remember the structure of the pons. That is the importance of understanding the or having the knowledge of basic neuroanatomy. Then coming to the Millard-Goldberg syndrome. This is very simple. This is nothing but ventral pontine syndrome. In this, it involves the facial nerve, okay? It involves the seventh cranial nerve. It affects the pyramidal fibers. This is the Millard-Goldberg syndrome, a ventral pontine syndrome, one of the ventral pontine syndromes. The other one being the this is the Millard-Goldberg syndrome. This is the Fowler syndrome. The other ventral pontine syndrome is the Raymond syndrome, in which the facial nerve is not affected. It involves only the abscess nerve. But the lesions of the facial nerve are limited to the two lesions. That is one is the Fowler syndrome, other is the Millard-Goldberg syndrome, in which the facial nerve fascicles are involved in this part of the infarction involving the pons. So Millard-Goldberg syndrome presents as as its name indicates, facial absence pyramidal syndrome. There is ipsilateral facial nerve palsy, ipsilateral absence nerve palsy with contralateral spastic hemiplegia. In this syndrome, the spinothalamic and medial lemnisci are spared. This is otherwise called the ventral pontine syndrome. Then another thing is the Mobius syndrome. It is because of the congenital anomaly in the facial nerve nuclei because of the failure to the development of this particular part of the brain. Also involves the absence of nucleus. That is, there is total underdevelopment of the sixth and seventh nerve nuclei, resulting in the bilateral facial nerve palsy, resulting in the inability to close the eyes, lack of facial expressions, inability to move the eyeballs laterally, and delayed speech, dental anomalies, high arched palate, chest and abnormalities, but intellect is intact. These are the features of Mobius syndrome, which is one of the rare disorders due to the underdevelopment of these nuclei of the sixth and seventh cranial nerves. This is one. Then coming to the lesions of the lower motor neuron. They could be extracerebral, intracranial, or extracranial. So intracranial portion of the lower motor neuron can be affected in that part segment of the facial nerve from the point of pontomedullary junction to its entry into the internal acoustic meatus. This is affected by the acoustic neuroma. The clinical presentation will be ipsilateral total facial palsy with ipsilateral eighth nerve manifestations. Well, in this particular lesion, long tracts are not affected. This point has to be remembered. This is to differentiate from the ventral pontine syndromes, like the Miller-Gobler syndrome. In Miller-Gobler syndrome, what is happening? There is involvement of the facial nerve and the seventh nerve, whereas in the extended Foley syndrome, there is facial nerve and the eighth nerve nuclei involved. So in this acoustic neuroma also, there is facial nerve and the vestibulocochlear nerves are affected. But the difference is in this lesion due to acoustic neuroma, features of the long tract lesions are not there. So this point has to be remembered. Coming to the lesions in the extra cranial part of the facial nerve. One is the external cranial part of the facial nerve. The one is it could be affected in the uh, vestibular canal or in the facial canal or before its exit in through the stylomotor foramen. This segment of the facial nerve could be injured by infections like herpes simplex, resulting in Bell's palsy, affected by the varicella zoster virus, resulting in the Ramsay hand syndrome, or Lyme disease, or due to demyelination, or vascular injury or trauma, or neoplasms. Well, this picture shows the patient with Bell's palsy on the right side. There is a loss of wrinkling, that is, in the frontal ring, the SOPA, and there is absence of the nasal labial fold and widening of the palpebral fissure. There is drooling of the saliva from the angle of the mouth, drooping of the angle of the mouth on the paralyzed side, and lack of wrinkling in the forehead on the side of the lesion. And very easy to diagnose the Bell's palsy by looking at the face of the individual. This also the photograph of the Bell's palsy of the patient, Bell's palsy on the right side. This patient is complaining of pain, probably is going to develop the features of Ramsay hand syndrome. It is because of the herpes zoster of the geniculate ganglion, resulting in the erythema, vesicles, pain in the angle of the jaw, followed by the ipsilateral total facial nerve palsy. This is caused by the varicella zoster of the geniculate ganglion. What are the other features? hyperacusis, loss of taste, tinnitus, vertigo, sensory neural deafness, nausea, vomiting. So the disease is caused by the varicella zoster of the genital ganglion and also involves the facial canal. And the condition shows variable response to treatment with steroids and acyclovir. Well, this is the brief discussion on the anatomical features and the clinical significance of the facial nerve. Hope you like this particular video. Thank you for the patient listening, and we'll meet again in the next lecture. Until that time, bye bye.